a little bit. So you guys forgive me, save your questions for the end, and then we'll ask him to clarify if there's anything we can't figure out when we go through it. But I think this didactic is pertinent, you know, with the state restrictions, but also sometimes we may not have a patient that we feel is quite ready to start Hep C treatment. So today's didactic is going to be about when Hep C treatment is to be deferred. The next slide. So per the IDSA and AASLD current treatment guidelines, it's on like the very first page when it says who to treat or who should start treating. The recommendation now says for all patients with chronic Hep C infection, recommendation is to go ahead and treat their hepatitis C, except if there are short life expectancies, so less than a year, I believe is what the current guidelines state, that could not be remediated by treating Hep C or a liver transplantation. And just kind of historically, remember, you know, before these direct acting agents were available, patients had to really go through rigorous pre-assessment tools, you know, assessing for other health conditions, the toxicity of the medication, psychiatric evaluations before they were considered candidates for treatment. And unfortunately, a lot of that has carried over with the new direct acting agents when those toxicities aren't still pertinent. So that's what the current national guidelines state. Oh, and I guess the next paragraph, he says, abandon the triage approach. So due to cost concerns, prioritizing patients who might benefit most from treatment was previously prioritized and had been I guess based on the degree of liver disease, manifestations, risk of transmissions. Again, they also took into other considerations with other health conditions. And now it's basically treat everybody unless you have a really good reason not to. And this is why. So, you know, so the idea now is, you know, kind of similar to the concept of HIV treatment historically. You know, before they didn't treat HIV until CD4 counts were below 200, and then they said, okay, 500, now they say treat everybody. This is similar, you know, now we know that treating Hep C early on really prevents progression of liver fibrosis and the resultant liver disease, and also there's a higher risk for development of HCC, and that's in the event of having already established liver fibrosis, there's still a little bit higher risk, about 5% risk, even after treatment. So try to treat them early so that you kind of eliminate that completely. Decreased all-cause morbidity and mortality, and then also quality of life improvements, mental health and physical health, regardless of what baseline fibrosis score is. And also treating hepatitis C. Remember, this is an inflammatory milieu, so treating Hep C early on might prevent extrahepatic complications or worsening of the below listed conditions: diabetes, cardiovascular disease, renal disease, and even development of B-cell non-Hodgkin lymphoma, which is really irregardless of baseline fibrosis level. And then again, the big one, to prevent forward Hep C transmission. We can skip that slide just because that's basically what we already talked about. So despite current guidance, again, patient treatment selection should still be individualized. So some reasons why we, you know, may want to wait or defer treatment. If there's and again, this is a lot of West Virginia basis because of what we're dealing with within our own state. So patient capacity to comply with treatment, we don't want to waste their, you know, with West Virginia guidelines, or Medicaid guidelines, it's really saying, you know, the one lifetime treatment course. And so we don't want to waste their one shot if they're not going to be compliant. Risk for reinfection. I actually listened to a webinar from Croy in March about hepatitis C, and it was funny because a lot of the speakers from Washington, Seattle, and California, and one of the physicians had talked about how they had treated this one guy 9 times for Hep C, and they kept justifying it because he was, you know, still in active addiction, and they were really aiming at preventing forward transmission, which I think is fine. It's just that we don't even have the capability to treat most of our patients here in rural West Virginia once. So, you know, risk of reinfection, I think that's more of a reason to treat. We just don't have that capability here. Medication interactions, the big ones, you know, the big ones that I've kind of struggled with are the anticoagulants and some anti-seizure medications. Sometimes, you know, if a patient if we aren't able to adjust therapy, or even sometimes anti-lipid agents, if we're not, you know, because of cardiac or stroke risk, if we're not really able to get an alternative regimen or be able to safely monitor patients through therapy closely, that may be a reason to defer while that's getting sorted out. Pregnancy or willingness to avoid getting pregnant while on treatment, especially if ribavirin is used. We rarely use ribavirin anymore, but none of these direct-acting agents currently have been approved for pregnancy. There was a study, though, recently, again, it was presented at CROI, and they had a really small population. It was maybe 26 females, but they actually did treat them during pregnancy with Harvoni, and I think it was even 8 weeks, if I'm not mistaken. I'll have to go back and look at the data. And so, I mean, there is some research that's coming out that's going to give us more support that it's safe to treat in pregnancy, or safer. We kind of generally think that it probably is, but that might be changing in the future too. Safety to the patient, so deferring treatment is particularly concerned if they're a decompensated cirrhotic. I would say, you know, you can consider treatment if they're a decompensated cirrhotic, but I would definitely have them referred to a transplant center or a hepatologist first. Ideally, if it's a decompensated cirrhotic, you're really concerned about worsening their decompensation on treatment. So, you know, safest thing is having at least transplant resources available in the event that they do decompensate further. Sometimes we've had transplant centers kind of give their blessing, and they help co-manage patients if they're decompensated. And then our digestive diseases section chief here at WVU Medicine actually recently came from a liver transplant center. So, you know, if you guys are in a situation where you do have somebody decompensated and you're trying to teeter about whether or not you should treat them, and they can't really get up here quickly, we can always reach out to the GI team and see kind of what their take on is, it if they want to go ahead and treat versus just watch and wait for transplant eval first. Failure of prior treatment regimens. We have a fair amount of, you know, a pretty good amount of data now with the new direct-acting agents. You know, there's a pretty good guidance on the Hep C treatment guidelines stating that, you know, if they're ribavirin, interferon treatment failures, there's really good guidance about how to retreat them with a direct-acting agent. We don't see as often, but we're going to, the more patients we see failures treating with direct-acting agents. So there's some data that says how to safely, you know, retreat. But again, in our state, unfortunately, it comes down to we don't have very many attempts, or it proves to be like more logistically retreatment is an issue. And then access to medication. So what do you do if you can't treat them, or if you're going to defer treatment? You know, at your follow-up visits, just making sure that you're providing ongoing education, reassure patients that, you know, this is a virus that, generally speaking, progresses over decades, not days. Also discussing more specifically transmission prevention, ongoing assessment of the risk factors, and then also, you know, reassessing for new risk factors at the follow-up visits, getting updated labs. Generally, I think if you're going to defer treatment and it's somebody that doesn't have fibrosis and doesn't really have any ongoing or recent risk factors, you may just want to follow their lab work. I'd say annually is probably not a bad idea. if it's somebody with advanced fibrosis, I'd say at least every 6 months. And if it's somebody that's got ongoing or recent risk factors, I leave that at provider discretion as far as how well you know the patient, just to kind of bring them in more for transmission prevention education than anything. HCC, so hepatocellular carcinoma, and varices screening if needed. Anybody that is F3 or F4, our Hep C treatment guidelines state that they should have liver ultrasound surveillance screenings for hepatocellular carcinoma every 6 months. And then EGDs for a varices screening if they're cirrhotic. I've talked with some of the GI colleagues, and really they state if they're elastography, which we don't always have access to elastography, but if you have a cirrhotic patient that's really well compensated, so their elastography value is less than 20 kilopascals, the median value, and if their platelet count is above 120, they really say you can technically defer their EGD screening. So it's not as urgent that you get them screened for varices every cirrhotic patient. And we kind of discussed that previously, in that sometimes we're not sure because our non-invasive markers are discordant. So that may help guide some of you also. Making sure that they're up to date on vaccines, assessing for symptoms, and then ongoing avoidance of hepatotoxins. So just a reminder, Hep C natural history education, the risk of developing cirrhosis, some data says 5 to 25% over a period of 25 to 30 years. Again, the whole decades, not days concept. And transmission prevention education. Blood donation. Patients should be advised to never donate blood or semen. They can donate, they're just going to reject it. So even if a patient's been treated, when they do blood screening, they're only going to do the Hep C screening test, which is always going to be positive. So unfortunately, your patients that really want their Hep C treated so that they can donate blood, kind of SOL, because they won't be able to still. And then transmission to household contacts, just reminding them to avoid sharing personal items, razors, toothbrushes, nail clippers, and cover bleeding wounds. Teach them about how to wipe down household surfaces if they come in contact with blood. So really a bleach preparation is your best chance of killing the virus. Drug use, we talk about that all the time, so I'm not going to go into that. Sexual transmission, there is a little bit higher risk of sexual transmission, generally around 2%, but in men who have sex with men, it's a little bit higher, around 8%. Hep C and HIV co-infection, it's about a third of patients that are HIV infected are also HCV co-infected. And then pregnancy again. About a 6% risk of vertical transmission. There's some factors that can increase that, HIV, ongoing drug use, if they have a viral load greater than 10 million. So that's kind of one of the only times pregnancy is when you should worry about a high viral load. Otherwise, it's not really indicative of disease progression or transmission risk. Go to the next slide, Caitlin. Addressing risk factor for HIV acquisition. We talk about this in our clinic a lot, unfortunately, but often it's the patient's addiction that causes them the most harm rather than their hepatitis C. And a lot of our patients come in and they're really, really stressed about their Hep C, and sometimes we can use that as a carrot for them to get clean if that was their risk factor, but more deaths occur from drug overdose or suicide than from Hep C infection. Keeping labs up to date. So CJ's intake form, ongoing screening for co-infections. HIV, it's variable. I say depending on how remote the risk factor is, but at least annual, biannual screening, As far as hepatitis B and Hep A, just vaccinate if possible. If they're a non-responder, you probably need to continue vaccinating for, or continuing following at least annually for Hep B titers. And then markers of liver fibrosis, various modalities. Liver biopsy is really the gold standard test still, but we tend to not use it anymore because of the associated complications. Serum biomarkers, elastography, APRI or FIB4, really trying to obtain as many non-invasive measurements as you can to really combine information to form a clinical assessment as to the degree of liver fibrosis. So just ongoing monitoring of those. And screening for Hep C or hepatocellular carcinoma when warranted. We talked about this a little bit. Let me just look at the slide better. Recommending ultrasonography at 6-month intervals. And then the combined use of AFP and ultrasound is not recommended by the AASLD. And I think that's more related to, in our practice and even with our digestive diseases team, they tend to do 6-month AP or AFP values on cirrhotics. I think it's not recommended by the AASLD because it wasn't AFP values, just because they can be influenced by multiple other conditions. We still do it here. If I have an AFP in like the 20s or 30s and I have a cirrhotic patient, I don't automatically always jump to an MRI. But if I notice they've had a normal AFP for pretty routinely and all of a sudden jump up to the 30s or 40s or hundreds, or certainly thousands, I may just forego the ultrasound and get an MRI instead with ongoing monitoring. Vaccinations, basically Hep A, Hep B, pneumococcal vaccine is recommended for all patients with any kind of chronic liver disease. So go ahead and get their Pneumovax. It's actually the pneumococcal polysaccharide vaccine, the 23-valent vaccine that's recommended with chronic liver disease. So even if they're less than 65, they should go ahead and get that shot. Annual flu shot, and then tetanus vaccine. Let's see. At your visits, reassess for symptoms. Chronic Hep C is not typically symptomatic. Most common symptoms, fatigue, might have nausea, right upper quadrant pain, just kind of generalized joint or muscle pains, sometimes appetite loss. But most of the time, the presenting symptoms are going to be from the cirrhosis itself and not from the viral hepatitis piece, if they're cirrhotic. And then just remember that there can be multiple extrahepatic manifestations. I can go to the next slide. Avoidance of hepatotoxins. So when we talk about the kind of linear progression of Hep C virus to advanced fibrosis and eventually liver cirrhosis, being decades, that's kind of taken off the table if somebody's drinking. And the analogy I make to patients is it's pouring gasoline on a fire. So any amount of alcohol, we really don't have a safe threshold of alcohol consumption. And so we still advise, abstinence from alcohol in patients with chronic Hep C. I do have discussions with patients. It's kind of hard to convince a 22-year-old not to drink ever at all for the rest of their life. So, if their liver enzymes are normal, if they're otherwise pretty healthy.
You're good, like coffee.
Yeah, you're gonna have to pick it up. I tell them we just don't really have a safe threshold, so we advise against it. But once their Hep C is treated, it doesn't mean that alcohol is off the table forever. And then NSAIDs to be avoided for patients at risk for GI bleeding, like our cirrhotics. Tylenol, we would prefer less than 2 grams every 24 hours. And then just making sure also to assess about non-prescribed medications, so herbals and alternative therapies. Gilfie's is going to take over because this is his talk.
Man, this PowerPoint sucks.
No, it's actually good. I just don't know it.
No, it's mine. I'm sorry. I already gave it before one time.
Before we go on, Dr. Peters had a question about sugar consumption. Is there a question?
Sugar?
High
Sure.
fructose corn syrup is really bad for liver disease
Huh.
patients.
Interesting.
I don't know.
I heard that. I was just kind of curious if that was something I always counsel my liver patients about that, my diabetic patients about that, but particularly high fructose corn syrup being bad as opposed to other forms of sugar. Whenever I'm counseling my diabetic patients about it, because every now and then somebody will remember the fact that fructose is just fruit sugar. And they'll say, well, does that mean that apples are bad? And I always tell people that I've never had not a single person ever give themselves diabetes from eating apples, but lots of people do it from apple pie. So it's like I just wasn't sure if that was something that anybody. I heard a hepatologist once at a conference make a really, really big deal about high fructose corn syrup and the way that it's metabolized through the Krebs cycle is like through the alcohol dehydrogenase pathway, and that seems to be more hepatotoxic and pro-inflammatory than consumption of other sorts of sugar. But I didn't know if anybody else talks about that or.
No.
I haven't, but I'll ask Dr. Hudson because he would know the answer. He's the section chief with GI. I'll ask him because he would. I bet he would know. I don't know. That's a really great thought.
Well, it's just like I don't know. It's weird because we make such a big deal about alcohol consumption, and then people drink, I don't know, Mountain Dew or Monster Energy drinks or whatever it is, whatever those things are. And it's actually, I mean, if that's equally bad, I don't know, I don't know. I'm just kind of curious. I just tell people when they go to the grocery store, just avoid the aisles, like just eat around the side, like the outside perimeter, but nothing down any of the aisles.
That's awesome.
Man, so that's hitting the produce and the dairy and
it is the meat.
Man, what cool advice. You know what?
Yeah, I really do. It's like I was like, that's where all the crap is. Like everything bad is if it comes in a package, you probably shouldn't eat it.
That's awesome.
It's interesting.
I'll ask him, Greg, because I think that's really great advice. I feel like now I should have been doing that my whole life because just about everybody comes in with their Mountain Dew. But I never thought about it before, till now.
I've switched over to a pure preservative and additive diet. I pretty much do. It's like yellow number 4 and a little bit of all those.
And he's really not joking.
I'm not kidding, actually. It's the worst part, yeah. So, I'm going to go from here. So what is this saying? HCV guidelines say, don't, you guys all know this stuff. Wait, this is, okay, sorry about that. Am I on the right slide? Yeah. Okay, this is a bunch of stuff I really do like. So this is kind of variables. We don't talk about these a lot because we just want to treat everybody. But when we talk about what makes fibrosis vary from one individual to the next. So, and there's obviously the genes we're born with, the human we are as our host, the environment. I really don't know what the environment means other than alcohol and hepatotoxin. And then there's specifics about virus, the particular viral process. So let's look through each one of these individually, and I think we'll talk about a couple of them in the next coming slides. So the fibrosis stage matters. In other words, fibrosis begets fibrosis. Inflammation grade matters. I think a couple basically echoes ago, Jennifer, I think you asked about the activity score. So it's going to be a inflammation grade. Activity score is the same thing, and this could be one of these independent sort of variables for disease progression. Age. So age matters. Older people progress with their fibrosis more quickly. We'll talk about that again in a couple slides. Gender. So gender, there's a couple important gender-based things with hepatitis C. And it tends to be, I should be more particular on this one. gender when you have estrogen. Okay, so post-menopausal women, with regard to hepatitis C fibrosis progression, behave like men. And so I think that's important because you can have a woman who has no fibrosis who goes through menopause and may have more escalating fibrosis then. Okay, so it's the impact of estrogens. And there also seems to be a protective effect early on where women are more likely to clear infection than men. So there's a couple different places where gender matters, but it tends to be younger gender differences that matter. By the way, I don't have this up here, but ethnicity is an important factor we don't talk about a lot. Ethnicity is very interesting impact, and in particular, it's African American. The impact isn't what you'd expect. So African Americans traditionally have had lower response rates to treatment. That's still something we consider, but if we even not talk about treatment and we just talk about rate of fibrosis progression, very interestingly, African Americans have lower rates of fibrosis progression. Okay, so lower rates of fibrosis progression, but I'm going to put a bunch of caveats on this, okay? However, African Americans have higher rates of hepatocellular carcinoma from Hep C. It's same for Hep B. So it's if you say, okay, so slow rates of progression, and in general, because of as a whole at our societal level and access to care, African Americans tend to present with later progressed disease and have worsened outcomes more or less because of access to care. So when we do see African Americans in care, even though truly they've had probably slower fibrosis progression, we tend to see more advanced disease. Okay, so that's again saying that we're having a lot of missed opportunities throughout the lifetime. And remember to make sure hepatocellular carcinoma gets screened for in our African American patients. Okay, so that's I don't even have ethnicity up here, but it does matter. And then organ transplant immunosuppression can obviously make our rates of progression. So if you have a patient who is a rheumatoid arthritis patient on immunosuppression, beware to watch those fibrosis scores. Obviously drinking, having other things wrong with your liver. Remember this weird relationship between sugar and hepatitis C. So hepatitis C can make people insulin intolerant, and insulin intolerance can make your fibrosis progression go more rapidly. So it's really a positive feedback loop with that. Now there's certain viral factors. We know that the genotype 3 progresses more rapidly. What would normally occur in 20 to 30 years tends to occur in 15 to 20. And then having co-infections with Hep B and HIV can make fibrosis progress more rapidly. And remember that whereas in HIV, the viral load is everything. In HIV, if you look at somebody and say, boy, how fast are you going to progress to AIDS? How fast is your CD4 cell count going to drop? How infectious are you, etc. For HIV, the viral load is everything. For hepatitis C, much less so. It doesn't often correlate with the stage of disease, okay? It's more the activity score that would matter, okay? So our viral load is more of a treatment. It's a way we confirm infection, and we follow it for confirmation of eradication of infection. But otherwise, it's not nearly as prognostically important. Questions on that stuff? So these things all make sense? Okay. Oops. And remember, this is the whole point. Fibrosis may not progress linearly, especially as we progress with age. Remember, especially in our women who go through menopause, may have more rapid progression all of a sudden. And that if you already have some fibrosis, those are the patients that are even more important to watch more closely, because fibrosis begets fibrosis. And Jennifer asked the other day what the activity score used for. Same thing. A higher activity score is going to indicate more likely risk for eventual laying down of scar tissue. If you think of inflammation as an endless cycle of scarring and, or I should say, damage and healing and damage and healing, and scar tissue being laid down. So it's that's what activity score is indicating. And then remember also that these values that we look at, our fibrosis assessments, our fibro tests, our APR indexes, our FIB4, and our elastography are not perfect, nor is the liver biopsy perfect. And so there are times when you will see an apparent jump or an apparent regression of fibrosis on these assessments of fibrosis, and sometimes it's within the error of the test, where you can see differences from one time to another. So the punchline of that is look at the trend. And remember, extrahepatic manifestations, you can get them unrelated to our fibrosis stage. And of the extrahepatic manifestations we talk about a lot, I know we mentioned the diabetes one a lot. We talk about kidney disease, we talk about lymphoma, we talk about rheumatoid arthritis, we talk about cryoglobulinemia. And when I was reviewing this slide set, I made it a point to go through and re-review myself what the impact of hepatitis C and cardiovascular disease is, because I think one of the most common comorbidities that we probably blow off, or I shouldn't say not blow off, obviously, but we don't correlate with hepatitis C, is atherosclerosis. So if we have patients with atherosclerosis, in other words, if we have patients, okay, because, again, we are the country of additives and preservatives and high fructose corn syrup and not shop in the corners of the grocery store, as Greg mentioned. So, but honestly, atherosclerosis is something that has been associated with hepatitis C, the inflammatory milieu that hepatitis C induces, the subtle, even unmeasurable. The punchline is that we have to draw that connection in our brains, and I think I don't routinely remember to think of cardiovascular disease as a potential, I don't want to say purely extrahepatic manifestation, but something that can be an extrahepatic exacerbation of hepatitis C. So an important thing for us to keep in our mind if we're trying to come up with a reason to get people treated and so on and so forth. How often do we see our patients again? Honest to gosh, the answer to that depends upon this, how many of these check boxes they click off. And so if you have a patient who already has some fibrosis, high inflammatory score, they're 60 years old, gone through menopause, on prednisone, obese with diabetes and genotype 3, gosh, I'd probably follow those people a lot. I'd probably follow them every 3 months or something, who knows. But otherwise, it's up to your best judgment. If you don't have a lot of those other risk factors for rapid progression, every 6 months may do. There's a slide I don't have on here, and it was something I had thought of. And the whole title of this talk is What to Do when Treatment is Deferred. And probably the first answer there is fight the deferment. So going back to like the second slide, I talked about this one. The most common reason that patients aren't treated is access to the medication, insurance. And I remember the various things you can do, and I was thinking about this morning. Number one, appeal, and I have not had personally much luck with appeal. That's like, to me, something that I guess I'm not eloquent enough to word my appeal well. Number one. Number two, obviously they can buy their medicine from Australia. Number three, you can move. I know that seems like a terrible plan, but I've literally had people do that. Our state is one of the few residual states that and by the way, to any of us, moving seems like a terrible idea, but a lot of our patients are fairly migratory. And, half of them when I mentioned it's like, oh gosh, yeah, I got an address in Pennsylvania and an address, I don't want to know the why on any of that stuff. But there are times when we mention this as an option. I recently had a guy who was like, oh yeah, I'll just go live with my mom for a couple months and get Medicaid there, and in Virginia. So this is something we can at least educate our patients on, that this restriction is state by state dependent. And so it's, buying the medicines. By the way, because a lot of times $650 or $700 is still a lot of money for people. So move, buy it, appeal. And then the last one I wanted to mention, because this is something becoming more and more important. If it's a patient that you feel it can be a squeaky wheel, empower them to be a squeaky wheel. So there's a couple patients I can think of off the top of my head where I didn't do anything above and beyond to get them treated. Standard appeal, but I didn't make any solid medical arguments. But man, they were a genuine pain in the butt. to Medicaid, and they threatened to, actually they did call the senator, and they called blah, blah, blah. And so they were really annoying. And one even recently threatened litigation. And gosh, he got treated within the day. It does matter how squeaky a wheel you are. And, honestly, gosh, we need some of these cases to go to litigation anyway. So we need to start advocating that our patients be a pain in the ass to the insurer. If they don't want to move to Virginia, have them write letters to their senator and as different options. But sorry, guys, if this is redundant. I just thought it's come up a lot with what do we do when treatment is deferred and how to manage them, but hopefully it's not terrible. So thoughts, questions, comments? Yeah, squeaky wheel. Have your patient have a squeaky wheel slide. Yeah. Isn't that cool?
That was great. Thank you. I find it helpful. I have one question about vaccination for Hep B and A. So after you vaccinate, should you draw titers, yeah, and follow them? I think Haley said that. I just want to verify.
For Hep A, I don't. It depends because the Hep A vaccine is awesome. One shot, you got 95% or 97%. Two shots, you got 99%. With Hep B, it really matters what vaccine you use. If we all just use the routine 3-dose vaccine, the low dose one, it's a fairly crappy vaccine. And so, and if your patient has ongoing risk factors, then it's probably worthy of assessing it. If you use the higher dose, less likely. And then if you use the new Hep B Slav, I can't say it's Hepsilav, the new 2-dose, it's a lot higher performer. It causes seroconversion at a much higher rate. So, but in all those questions, I would say the assessment of Hep B conversion depends on ongoing risk factors. If you diagnose this thing in somebody whose exposure risk was 30 years ago and they're not in the healthcare field, and it's even questionable if you need the Hep B vaccine. But the Hep A vaccine for certain. And the other one of the vaccine series that I think we all underdo, at least I got to speak for myself, is the pneumovax. We don't think of it unfortunately we all associate it with pneumonia vaccine. Remember, it's not a pneumonia vaccine; it's an invasive pneumococcal vaccine. So you're trying to prevent bacteremias and meningitis and seeding of other areas in the body. So the liver is an incredibly important immunologically active organ, making a lot of parts of our innate immune system, including complement and so anything we can do to boost our defenses against some of those really primary pathogens like strep pneumo and stuff like that. It's important. So
thank you.
Yeah, great question though. Answer is case by case. So yep.
I think Carmen said, do you do both pneumococcal?
No.
The guidelines are just for the pneumovax.
Yeah, great question. So about Prevnar, so do you do the protein conjugate Prevnar versus the polysaccharide pneumococcal or pneumovax 23? That only if they're over age 65 would you necessarily have to give them the Prevnar 13, because that'd be an independent indication. But no, liver disease is not quite immunocompromising enough to be considered an indication to give Prevnar 13. Keep your eyes posted on that one though. That changes every year. They've been more and more liberal on who to give the Prevnar 13 to. Good question. And by the way, I can never keep track on Prevnar versus pneumovax unless I read it about every 3 months, and then I can remember it for about a week. So, because there's so many. By the way, it looks the way flu vaccine used to look. If you remember, there was like 13,000 indications. Then the CDC just changed it in 2004 or whatever. It just said universal vaccination. I'm hoping that happens for pneumovax and Prevnar at some point. It'll just be more universal. But
cool. Do you guys have any other questions about this or about anything?
have you guys seen any really rapid progression of fibrosis, just out of curiosity, like anecdote level, where you've seen somebody go kind of from an F1 to an F3 or anything?
I had that one, I don't know if you remember this, but I kind of mentioned this. I had a patient that regressed really rapidly. He was an F4, and I was in the process of getting him approved for treatment, and then he relapsed on drugs, became homeless, and lost 60 pounds because he had been abusing drugs and not eating regularly. And then we rechecked his fibrosure, and he was an F0. I think, which I think kind of, underscores what we've said many times, is that this is a treatment algorithm that takes into consideration an awful lot of things and overestimates and underestimates. I mean, there's a standard of error, I guess, built into the fact that we're doing this test non-invasively. But it was interesting. He ended up moving away, so I never got the opportunity to commit mild medical fraud and ignore that one when I advocated for his treatment. But it was kind of an interesting. I mean, it's an interesting. I don't know. I guess kind of an interesting takeaway.
It is. Maybe he moved to a state where there's no fibrosis restriction.
Yeah, right.
We can maybe move to Virginia.
Yeah, I've treated 2 postmenopausal women now, and was kind of interested in what you said about that, because neither one of them had a major issue with fibrosis, which is good. But and I suspect at least one of them had it since a transfusion, in 1980. So.
Yeah, it's one of those warnings. They always say, don't, if you've been following a person for years and they're running along at F1 or F2, just worry when they go through menopause, you may have more rapid fibrosis progression. I've not personally seen it either. It's just something that all the textbooks mention that we've got to be careful of. So.
I have a question, and really this, I think, is for Dr. Peters and Dr. Rexroad. As I'm accumulating cases of people who I don't really know, I'm wondering if you all have a spreadsheet or a system or a tracking mechanism specifically for your Hep C, cohort, just to keep track of everything, who you've presented the echo, who you've sent in for medications, when they're due to come back, just all those things. It's a population. A lot of mine, of course, are coming from our MAP program, and it's a population that they're really high risk for not remembering to come in or being able to come in. And I feel, it's interesting, I feel more of an obligation than I do with, say, my diabetics to have a mechanism for follow-up.
Yeah, I sort of keep a paper list, but then also use the tickler system in the electronic record in terms of, nagging them to come back. But I just sort of keep a file, paper file of who I've presented and that sort of thing. Nothing formal. Okay, good, thanks.
A lot of what I do is they look sort of like consult notes, because I end up seeing them once or twice, for one of my colleagues, just to make sure that they're up to date on everything, or treat them and then send them back. I mean, that sort of thing. And they're managing all their primary care stuff. Yeah. I do most of that, like actually just through their problem list. So just on their problem list, just what their subtype is, what their fibrosis score is, when it was last checked. I mean, just kind of simple things like that. And then our EHR lets us run lists of patients based on like ICD-10 codes that they have there on their problem list. So then since chronic hepatitis C or whatever is on their problem list, then we can pull a list based on that. But a lot of that stuff, their primary care doctors are, and it'll say anything, like it'll say recommend like a Q6 month ultrasound because they're an F3 or higher or whatever it is. And so then a lot of that their primary care doctors are doing. So it's coming back. But I do all the stuff like their vaccines and everything, like their Hep A's and B's and their 23s and Tdaps and yearly flu shot. Like I have kind of a whole template that just kind of does that. And it's simple things like that, even just yearly flu shots and so on and so forth.
Thank you both.
I prescribe them
one thing, Jennifer,
any excuse to do so.
One thing, Jennifer, we did was put in an order set in our electronic record for all those initial labs. Yeah, and that makes it a lot easier to get them all and not miss any.
Right. That's a great idea. And do you have Athena too, Dr. Rexroad?
Yes, we do.
Okay, I know. Greg,
So do
you-
we, actually.
Yeah,
That's-
great. Okay, that's what I thought you did. Yeah. Okay, great. That's what I have. So, great suggestions. Thank you.
I wonder if we could send you our order set somehow.
Oh, that would be great. Or
I'll
have
ask that question.
yeah, have my guy, your guy, talk to my guy.
Yeah, why not?
Right,
You don't
right,
need to reinvent the wheel if you don't have to.
right. Yeah. Okay, that's helpful. Thank you. It's all care management, you know.
By the way, after this echo today, I'm going to the grocery store, Greg. I need to figure out if you're right about it only being the peripheral of the store that I
It
need to
is.
go in.
Man, I'm telling you, it's like you start looking. It's wild. You start thinking about it because particularly high fructose corn syrup is interesting. You could do almost an entire didactic just on that. It's in freaking, like, it's in hot dogs, like it's in white, like when you buy bread at the store, like it's in that, like it's literally every single aisle in the grocery store. It is brilliant organic chemistry reconstructions of things that started off as corn, and it's amazing to see. Like, it's really amazing to see what food chemists can do. Like Oreos should not be made out of corn, but literally every part of an Oreo is made out of corn. There's no cream in the cream. Like, how crazy is that? It's all starts out as corn. How crazy! It's like, I don't know. It's wild. And if they shouldn't eat it, first of all, they shouldn't eat it, right? So it's like but it's interesting. You walk down the aisles of the grocery store. Most of it started off as corn, and it ends up as high fructose corn syrup. Here's another interesting thing. Did you know? You probably do, but it's did you know that America grows 4,000 calories per day for every man, woman, and child living in the U.S. in just corn?
Wow.
Like, isn't that something?
That's
You know?
wrong. That's something
And
wrong.
we bitch and wonder and complain and like, what are we in medicine doing to fight the obesity epidemic? And it's like,
What you just describing that to me made me want a cornbread muffin so bad.
I know, man. I had cornbread last night. It was so good. That's great.
I want 4,000 calories worth of cornbread right now.
Yeah. Hey, some of us are trying to buck the trend. We do grass-fed beef.
Yeah.
There you go.
It's the way to. I'm waiting to the biggest thing in my life is going to be the
Gosh,
the
impossible.
the Impossible Whopper coming to Burger King.
What's the impossible? I don't know what you're talking about.
Afraid to ask.
It's a plant-based Whopper that bleeds and gets grilled. But anyway, it's going to change the world. I'm pretty sure. It's going to change my mornings. I know that much.
Well, yeah, what I heard on the news yesterday, yeah, Arby's is doing what they call a merit. It's like a turkey made in carrot juice made up to look like a carrot. It might be healthier than some of their other stuff.
Oh, people.
You got to respect that commitment, though. Like, that's really like they know what they're like. They're not trying. It's like Taco Bell. That's a company that's never lied to me. You know, like they make no apology. Like, no, it's not healthy, dude. We're putting a Dorito inside of we're putting a taco inside of a Dorito. Get down here. You know what I mean? Like, they're not trying to win any awards. Fourth. They have to call it fourth meat. Like, they can't call it food for legal reasons. You know, like,
I love it. It'll make me hungry though. I'm gonna.
Yeah.
Time for some chicken nuggets.
Absolutely. Yeah. Well, thanks, guys. We'll do some. I'll rehash a couple of the old didactics we got because some of them have new drugs and crap on them. We can talk about, so it'll be fun.
It's great. Thank you, guys.
Thank
It
you.
was great.
See you guys next
See ya.
time. See ya.
Hey, Caitlin, I have an idea.
Yes.
It's